Alrighty, so for this one, let me share my screen. Okay, so for this video, my name's Elizabeth Freudenberg, and for this video, we're going to be talking about ARDSnet protocol. So acute respiratory distress system syndrome protocol. So these are some of the inclusion criteria for ARDSnet protocol. So basically, like PF ratio, like kind of like what we went over in the last video, is a degree or a measurement of the severity of ARDS or acute respiratory distress syndrome. So if we can measure the level of hypoxemia and the degree or the decrease of compliance, then we can kind of see where the patient is at in terms of their severity. So when you're talking about a PF ratio less than or equal to 300, we're talking about more of a mild ARDS. Less than 100 is severe. Less than like 100 to 200 is moderate. And then like 200 to 300, somewhere in there is more, it's considered more mild. You'll also have bilateral, patchy, diffuse, or homogenesis infiltrates consistent with pulmonary edema. So we mentioned ruling out pulmonary edema. So we'll definitely want to do that when it comes to an ARDS diagnosis. But a lot of times the symptoms are the same or very similar. We're talking about ARDS versus pulmonary edema. Not all the time, but some of the symptoms. And then lastly, we don't want any clinical evidence of left atrial hypertension. So these are some of the initial vent setup or vent settings that we want when we're first putting the patient on mechanical ventilation. So majority of, I'm sure we already know this, but ideal body weight calculation, or the PBW, for males, it would be 50 plus 2.3 multiplied by whatever inches they are over 60. Excuse me. So like 5'3" would be 3 inches, 5'6" would be 6 inches. For females, it'd be 45.5 plus 2.3. And then you would select any vent mode that was appropriate for the patient. So depending on the patient, depending on the hospital protocol, depending on their situation, like if they, came out of surgery, a lot of times the surgeons or the pulmonologist will want them put on specific settings when they first come out of surgery. And then it gets adjusted over time based off their symptoms, their compliance, all that. But sometimes it is really hospital protocol. Some hospitals really prefer like ACVC plus, or they prefer SIMV. So it really just like depends on the hospital and their protocol. And then an initial tidal volume of 8 milliliters per kilogram of ideal body weight. And then you'd be reducing the tidal volume by 1 milliliter of kilogram at intervals less than or equal to 2 hours until the tidal volume reaches 6 milliliters per kilogram. So it's really like that stair-stepping, that gradual decrease that they're looking for. And then setting an initial rate to the approximate baseline minute ventilation, as long as it's not exceeding 35 beats per minute. And then adjusting the tidal volume and the respiratory rate to achieve, an optimal pH and plateau pressure. Okay, so here's some of the goals. So for their oxygenation goal, we have a PaO2 of 55 to 80 millimeters of mercury, or an SpO2 between 88 to 95%. So in this situation, because of, you think ARDS, you think stiffness in the lungs, right? We got fluid in the alveoli sacs, um, and we have decreased compliance, right? So minimal PEEP is really important because we don't want to add excess pressure to entry. So typically, you'd see a minimum PEEP of 5 centimeters of water, and then either a lower PEEP and a higher FiO2, or a higher PEEP and a lower FiO2. And when they say higher PEEP, I still think they're referring to, on the lower end of high. But it's also just dependent on that patient and how they react. Some patients just, handle PEEP better, and then others don't. But we also just always want to be mindful of the patient, right? If they have ARDS, they're going to have that stiffness. They're probably going to have even like decreased vasculature in a sense. So adding that pressure or too much pressure can be like really harmful to their lungs. And then when we talk about a plateau pressure goal, we want to be ideally less than or equal to 30 centimeters of water pressure. Kettering is really adamant about that 30, so it makes sense that it's an ARDSnet protocol. Want to check the plateau pressure every 4 hours after each change in tidal volume or PEEP. We do that by initiating a 0.05 second inspiratory pause, and that gives you a plateau pressure. If the plateau pressure is less than 25 centimeters of water and tidal volume is greater than 6 milliliters per kilogram, you're going to increase the tidal volume by 1 milliliter per kilogram until the plateau pressure is greater than 25 centimeters of water, or the tidal volume is equal to 6 milliliters. So we're just kind of trying to balance those numbers out. If the plateau pressure decreases to less than 30 centimeters of water and breath stacking occurs, or some type of desynchrony, right? We want to increase the tidal volume in 1 milliliter increments to 7 or 8 milliliters per kilogram. If the plateau remains less than or equal to 30 centimeters of water. Alrighty, that is pretty much it. Sorry, I think my screen kind of froze there for a second. Thank you so much.